Heart injury. Discuss in general differentiate between myocardial contusion and infarction. Add a note on the rupture of the heart. The heart may be injured from a non-penetrating or penetrating trauma to the chest. Injury is usually associated with injury to other structures of the chest. It is not commonly realized that cardiac damage, especially contusion, due to non-penetrating trauma occurs frequently and is often missed since signs and symptoms including alteration in the electrical activity such as shown by ECG that often do not appear until 24 to 48 hours after injury. Sometimes a posterior cardiac contusion may be mistaken for postmortem lividity and vice versa. A cardiac contusion shows a microscopic examination, localized interstitial hemorrhage, and injured myocardial fibers. Myocardial contusion. Myocardial confluent petechiae on heart surface. Localized interstitial hemorrhage and injured myocardial fibers. A mild or moderate non-penetrating cardiac injury may lead to sudden death with or without visible lesion or may cause symptoms of cardiac insufficiency, angina pectoris, auricular fibrillation, or valvular rupture. When there is no visible lesion and death occurs after a sudden blow to the chest, it can due to arrhythmia and even significant microscopic findings are not seen. The condition is sometimes referred to as a comatio cordis. The diagnosis depends upon good history. If force is applied during the contraction phase of a heart, a partial rupture of the papillary muscle may occur. Pincer lesion of the heart is commonly seen in compression injury as a contusion of right atrium at the entrance of the inferior vena cava and produced by impact over the chest in the region of right cardiophrenic angle. With a severe violence, when a driver is forcibly thrown against a steering wheel, the buckled sternum may contuse, crush, rupture, or avulse the heart from the major vessel. Differentiating between a myocardial contusion and myocardial infarction is not always easy. Absence of coronary artery disease and a spotty distribution of the heart lesion may strongly suggest a diagnosis of trauma. Medical and legal implications of a contusion of myocardium are great. If the physician fails to recognize such a lesion allows full activity, the patient runs a higher risk of dying from a rupture of the injured heart with a resulting hemorrhage, heart failure, disturbance of cardiac rhythm, especially ventricular fibrillation. If intrapericardial bleeding occurs from the site of contusion, circulation may fail due to cardiac tamponade. The bleeding may be rapid or slow. If rapid, the collection of about 200 to 300 milliliter within 24 hours is usually sufficient to cause death by cardiac tamponade. Whether a certain trauma would conduce the heart depends on many factors, which includes the nature of trauma, age of the victim, and his health. Cardiac contusion may occur after relatively minor trauma to chest wall with very little or no evidence of external injury. In youth, chest wall is more resilient than in advanced age, hence a blow is more apt to damage the heart in the young without apparent injury to the chest wall than the aged. Coronary artery disease in the older increases vulnerability to the heart to damage and disturbances from traumatic force. The relationship between chest trauma and coronary artery spasm or coronary thrombosis is acceptable only if symptoms follow immediately and there is evidence of injury to the affected vessel. In the event of death at autopsy, the character of the thrombus and age of the myocardial infarct should correspond with the duration of the interval between the injury and death. Penetrating wounds of the heart are extremely serious and usually fatal. A rupture of penetrating wound of the atria is more dangerous than a wound of the ventricular muscle because auricular wall is thin, less contractile, therefore bleeds profusely. Similarly, a penetrating injury of right ventricle is more dangerous than of left. Death is not an immediate fatal cases. Death may be delayed in those cases where valvular mechanism exists for the entry and exit of blood into the ventricles from pericardial cavity after penetrating wound. The potential of a violational act after stab wound of the heart must be remembered. According to Moritz, the common site of traumatic rupture of the heart are right atrium, left ventricle, right atrium, left ventricle, right ventricle, left atrium, intraventricular septum and valve. Any traumatic rupture of the heart, most differentiated from spontaneous rupture, Traumatic rupture, the heart is generally ruptured on the right side and towards its base. The ribs and the skin over them are usually damaged. Rarely, the rupture may occur without any external mark of violence. Spontaneous rupture of healthy heart is not possible. An unhealthy heart, especially the left ventricle weakened by coronary artery disease or infection, can rupture under increased blood pressure and sudden exertion. Thank you.